All right, I'm going to go ahead and get started. Hi, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website on our Impact seminar page. I'll post the link in the chat, along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, the next seminar will be on December 2nd with Dr. Anna Ostroplitz. And with that, I will turn it over to Dr. Tim Beebe to introduce our speaker.
Thanks, Andy. Good afternoon, everybody. It looks like we have 50 plus people online, so that's a good showing. We have a big draw today. Today's topic is of central importance to our center and the work that we do generally. So patient-centeredness, activation, and engagement is central to the work that we do. And I'm thrilled to welcome and introduce today's speaker, Sophia Walker, who is well positioned to speak to these critically important matters. Sophie holds a Master of Science degree in Health, Community, and Development from the London School of Economics and currently serves as the patient editor for the BMJ. She's built on her experience living with type 1 diabetes since the age of 6 to advocate for the increased role of the patient perspective in the treatment development, healthcare delivery, and outcomes research. She has a background in clinical trial management, pharmaceutical market access, and commercialization and communication strategies. She was previously the Accelerated Access Lead at the Juvenile Diabetes Research Foundation, or JDRF, UK, the Type 1 Diabetes Medical Research Charity. You can see the title of her presentation today. So with that, I'll hand it over to Sophia to walk us through this important topic.
Thank you so much, Tim. I come to you from Cambridge, Massachusetts, where it is very windy. So you may hear some wind in the background, but let me know if you have any trouble hearing me. I was given in elementary school, we did a presentation on states, and I was given Minnesota. So I have a special affinity to Minnesota, despite never going there. I wish I could be there in person, but I will not be giving you a presentation on your state today. Don't worry. Today, let me see if the slides are moving. Did it go to the next screen? Yes. Okay. All right. So today I'm going to be speaking to you about 4 things. I'm going to start with my background, or why I'm here in front of you, what gives me the right. Then I'll be moving on to the BMJ, formerly known as the British Medical Journal. That's the journal where I work, and the patient and public partnership work there that I do and others do. And then I'll move on to the BMJ and World Health Organization, or WHO's collaborative publication, which I will be referring to as the collection on lived experience as expertise. And then there'll be some audience participation at the end, where I will be asking you some questions about your work and how it relates to what I've just been presenting on. So this is my narcissism slide, so please excuse all the pictures of me. But this is just to explain how I became involved in, and I'm going to use patient and lived experience interchangeably. I know there are challenges with both, especially patient. Some people are moving away from that terminology, but just using it as a catch-all term because it is still very much used and still used as the BMJ. So bear with me as I go between patient and lived experience and other similar terms. So how did I get into this work? So my background, if you know other people in this work, you probably will hear similarities. So I was diagnosed with type 1 diabetes at age 6. I was living in Cambridge, Massachusetts at that time. So I went over to the river to Boston Children's Hospital. On the left here is a picture of me looking pretty grim at diagnosis. But the picture on the right of me in the yellow shirt, that's in the garden at the Boston Children's Hospital. And that's more of a representation of my mood. I actually really loved my time there. And I think that really set the tone for my experience with my condition. Just that they made it really fun, if you can believe it. I was also on a floor with kids with cystic fibrosis, and that really gave me perspective. I used to fall asleep hearing their backs being kind of pounded. So definitely gave me kind of perspective on other conditions. So meanwhile, oh, I also should mention I had a stroke at age 10. So back I went to Children's Hospital, and I actually met my an endocrinologist during that experience, who became my endocrinologist till I was about 22. She was a pediatric endocrinologist, and she eventually had to kick me out from her services. And then I was also diagnosed with long COVID while living in London, UK. So I lived in London for 15 years, and during that time, during the COVID years included, I guess the COVID years are still going on, but the beginning of the pandemic, and I had suspected COVID in February 2020, and then really had a hard time recovering, and then went to a COVID clinic there. And that was a real juxtaposition between type 1 diabetes, where the evidence base is really clear. It's more about just how treatment can be approved, but a very kind of recognized condition. And also living with long COVID, which is, the evidence base is still evolving. The recognition for the condition is still evolving. So that kind of opened my eyes to living with different conditions. So meanwhile, my career background was in very much kind of biomedical, working in R&D, working mainly in pharmaceutical development and regulation. Eventually, I was a pharmaceutical consultant, working on marketing and communications. But in my free time, I was doing more patient advocacy work, specifically for type 1 diabetes. And it just seemed like such a disconnect during my day job and my volunteer work, because I kept thinking during the day, like, where is the patient voice? Where's the patient in all of this? And then I just decided I wanted to kind of bridge the two sides and make it my career. So my first kind of job in patient advocacy was at JDRF, which is now called Breakthrough Type 1. And I leaned on my skills of getting treatments through the market to work on a big project called Research to Reality. That was really about how accelerating treatment to type 1 diabetes in the UK, how it could be accelerated, but also how everybody could get access to this treatment. And then that brings me to this last picture of me standing in front of the British Medical Association. And that was that's where the BMJ used to be, its office. It's since moved, but in London. And that was in April 2022. And then I moved back to Cambridge, Massachusetts a few months later, but I kept my job there. So you'll probably see some English, some British English, American English, all different kinds of English in my slides, because I go between them. I also often go by Sophia in the UK because there's so many other Sophies. So any kind of publications are under Sophia, but I go by Sophie casually. So focusing on this last picture, I'm going to now go into the work of the BMJ. Just waiting for the slide to go. Okay, so this is on the BMJ website. This is the Patient and Public Partnership Strategy. The BMJ is unique in being one of the top general medical journals that has a clear strategy for patient and public partnership. I'm just going to read you. And you can see the website is there. I'm just waiting for the next slide to load. Oh, here we go. Okay, so the really guiding principle for the BMJ strategy is, I'm just going to read, apologies, but I'm just going to read this to you. The BMJ believes that partnering with patients, their carers, support networks, and the public is essential to improving the quality, safety, value, and sustainability of health systems and research. It makes content more practical and relevant for clinicians and helps to ensure that the knowledge we produce is of value to our readers. So a little bit of history for the BMJ's patient partnership strategy, its origin story, if you will. So the official strategy was launched in 2014. But pre-2014, the BMJ had historically had a focus on making sure the patient was represented, the patient needs, the patient voice was represented in the journal's publications. And it's just in 2014 that became formalized, so less ad hoc and more actual guidelines and principles. On the left, you'll see a cover from 2003 showing a patient-focused issue, even though the strategy hadn't launched yet. And then on the right is an image from 2014 when the strategy was launched. So the 4 pillars, I'm going to really simplify this. It's all online. You can ask me questions about it after as well. But the 4 pillars of the patient-public partnership strategy at the BMJ are patient authors. So we have a series that is written by patients or carers or people with lived experience. It's called What Your Patient is Thinking. We also encourage patients to author manuscripts for other sections, or also to co-author with maybe academic or clinical writers, or have patient perspectives. There are different avenues in which patients can contribute writing to the journal. We also have a patient reviewers, so all research manuscripts do go, or try to go, at least go to patient reviewers. Not, they don't always accept, but they try to get 100% of our research manuscripts reviewed by at least 2 patient reviewers. As of last year, we now pay our patient reviewers so they can get £50 or equivalent in other currency, or a free subscription to the BMJ, or there's also various other specialty journals, about almost 70 specialty journals under the BMJ. And then you all are probably, or at least some of you are familiar with requiring PPI statements and research submissions, so that when there is a research submission, there is a statement that the authors have to submit about whether they included patient and public involvement or not. We're working on that to make it less binary, yes, no, and more details about why they did or did not include patients as in co-production of that research. And then we have patient editors, so such as myself. Emma Doble is another patient editor who many of may have heard of. We also have a patient advisory panel that are people based around the world and in different conditions, and they surface what's going on in their geographies and their conditions. And we have an annual meeting with them, partially in person if possible, and then we have meetings with them all the time, and we have a Google group, so we're always in contact with them to make sure we are surfacing and we have things on the radar that are important globally. So just a fun fact is this picture, this image on the left is from a July 2024 patient-led issue. So this was an issue that was edited and written by patients. It was very rewarding. Took a long time. It was quite challenging, but very rewarding process. Even picking the cover for this took quite some time, but hopefully you all approve of the cover. So moving away from the BMJ strategy, the day-to-day work of the BMJ strategy, I'm going to now focus on that collection. And this is really the real reason I was asked to talk to you today, is this collection, which is a publication between the WHO and the BMJ. So hopefully I've proved the BMJ's kind of patient and lived experience prioritization chops, which is why the WHO came to us to ask us to work with them on publishing some content, which I will go into in a moment. But first, as I'm sure many of you have noticed, lived experience and patient engagement, patient involvement, all the many terms, is really gaining traction, gaining recognition. I always laugh like, oh, maybe I can, my work here is done. I can go follow my bliss and be a carpenter, which is my dream job. But I know it's not time quite yet. I would say there is greater valuing, greater appreciation of the expertise that patients and people with lived experience bring to health decision making, just to make things more relevant and equitable, more grounded in the reality of people's lives. But it's a lot about, and it is disparate, depends on which geographies, which kind of disease conditions, but really what's challenging for many kind of policymakers is how. So the why, we're getting there with the why, but the how is really challenging. But in 2023, I'm just going to move on. I might come back. So in 2023, the WH published a framework for meaningful engagement of people living with non-communicable diseases, mental health, and neurological conditions. And this was a really kind of guidelines and guidance, more like it, on how to support the co-creation of people with these specific conditions. And while it is for these conditions, just because the WHO has identified these as the most kind of the biggest burdens that will prevent from their big SDG goals, it is applicable for other conditions as well. So really this framework was to support co-creation and kind of brass tacks guidance for how to do it. So that was 2023. Meanwhile, 2024, the social participation resolution was approved by member states of the WHO. And this was really a political instrument to keep governments accountable to the core processes and concepts of meaningful engagement. So governments, it's a way for them to position lived experience, expertise as embedded in the health system and not just kind of ad hoc or tokenistic way. And governments are held accountable. The governments who sign this are held accountable. And I have the websites if you want to learn more. So one of the main challenges is, so not the how, not the why so much, but the how, and something that has been identified by the WHO and many others is there's gaps in the evidence base of incorporating lived experience into health policy making. And when I say health policy, I mean health policy, health research, healthcare delivery, education. I know we often talk about research and much more kind of RCTs, clinical research, and bringing the patient expertise into that. But this was much more big picture. I mean, it includes that, but it's really healthcare or health, even decision-making writ large. And there's a real acknowledgement that decision makers, policymakers want to work with lived experience. They're recognizing that it saves a lot of time in the long run, money, et cetera, but how do you actually do it? So the WHO came to the BMJ with and had identified some people or a number of people working in lived experience with lived experience working in policy change and doing really important things despite a system that wasn't really supporting them. And this was a way of highlighting those people and what they've been doing in a way that could offer lessons to other individuals, but also to more foundational or system level ways. So let me go to the next slide. Oh, and I should mention that it was published this July, this collection. And the WHO, it was proposed by them. They paid the open access fees. They paid the lead authors, because that is one of the things that has been highlighted about lived experience is actually paying people for their time and expertise. So made sure to pay the authors. And then the BMJ peer reviewed, edited, and made which decisions about which articles to publish. So I was one of the editors for that. You can see my face there. And there was a total of 8 articles that were written. There was the leading editorial, which was written by me and some two co-authors. There was an analysis piece, which is a debate with data, and it has to consider more than one side of an argument. It's an even-handed look at the data, and then 6 opinion pieces, which still evidence-based, but more of a personal view or blog style. And one thing that the authors were very kind was that they let me interview them about their experience working on their articles, because it was, challenging for the authors, for the editors. These aren't people who are writing these types of papers all the time. They're not churning them out. Even those who do churn them out, it's difficult. So it was a long process. It actually took about 2 years from the start to publication. And then I wanted to let you hear directly from one of the authors. This is Emily Ng. She wrote the analysis piece. So this is one of the longer pieces. And she speaks about her lived experience in dementia and working to increase inclusion of people with dementia and health decision-making in the Western Pacific region. So let's see if this works. I'm gonna play the whole thing so you can hear from her directly, and you can stop hearing my voice for a while. You can have a break.
If there is no legal mandate from the government to say that, okay, the voice of the people with lived experience need to be included, then it is very difficult for the people with lived experience to really involve in decision making and influence the policy. Yeah. So because when I see the difference of my involvement in Singapore and my peers in Japan, it's so different. Let's say when we talk about making the changes for the people living with dementia in the environment, it requires the multi-stakeholders involvement and things like that. So if the people with lived experience is not divided and sit on the same table and have the equal decision-making power, then our work is restricted. Whereas my peers in Japan, they are invited to be on the same table with the decision maker. So then it is easier, much easier, more influential also. So if you want to have the people with lived experience involved, it has to be a legal mandate. It's very important. Because of the self-stigma, that they felt that they are not good enough or no longer competent enough to contribute to this kind of thing. And of course, the self-stigma also comes because of society, the way society look at them. So that is, if we can help to reduce the stigma, whether is it from the society or from the individual, then it will make it more possible for the involvement of people with lived experience.
So that was one of the authors, and I'm going to see if this works. I wanted just to show you the web. Oh, let's see if I can. No, that is not going to work, is it? I just wanted to give you, well, so that was one author speaking, but you can go to this site here at the bottom. It was supposed to link to it, but of course it's not right now. And you can read the articles, and you can also, some of the articles include videos like this one of Emily, and it's really powerful to hear the authors speak about their own experience, like Emily with kind of trying to confront stigma in her own life, but also in her work. Yeah, so we hear about people's lived experience and how their personal work, and also how they do it to kind of change policies and change things at the systems level. What I'm going to do is it's audience participation time, and I'm going to ask you, and then I'm going to go try to see if I can bring up that website that doesn't seem to be working right now, so I can show you a little more about the lived. I'm just looking at the chat, make sure I'm not missing anything. Okay, so audience participation time. So what connections and relevance do you see between lived experience and health decision-making and learning health systems? I mean, this probably seems like a really obvious, simple question, but I'm wondering if there's any kind of new insights you've had, or I would love to hear more about your work and what your experience has been with working with patients, or if you want to do more of it. And then that can hopefully segue into any questions you have for me. So I'm going to turn it over to you now. And I'm going to see if I can find the chat, see if anything's come in. Andy, should I just wait for a chat, or do you think can people?
It looks like we have someone raising their hand.
Oh, okay. Sorry, I can't see.
Oh, no worries. I'm gonna allow them to speak. All right, Gretchen, you should be able to talk now.
Thank you so much, Sophie, for this presentation. I definitely find value in having lived experience in all of my studies. I think especially when we're thinking about being a learning health system, we're already trying to be responsive to what's going on in the health system when we're thinking about how to improve care. And so to me, it just seems really natural that you also would include patients' perspectives on that. That being said, a lot of the time, I think people think that it would be hard to get patients' perspectives, but I've actually found that patients are very excited when they're asked to participate or to give their opinion. And I've actually, on one of my studies currently, I've had way more success at recruiting patients and getting their perspectives than I have the healthcare providers and staff. So I think that just kind of speaks to, how patients really want to be a part of improving their care, and that they have really good insights that you can't get anywhere else.
Gretchen, thank you so much. That's really, really helpful. And what you said about sometimes the patients are more willing to provide feedback, or advice, opinions, what have you. We have that at the BMJ with reviews. Sometimes the patient, it's a lot easier to get patient peer reviewers. than other peer reviewers. And we thought when we started paying patients, we're like going to have this whole onslaught. And a lot of people, that's, that's not why they're doing it. I mean, we do want to be very aware of like equity and people's time and not just, kind of exploiting people. So yeah, we do definitely want to offer payment, but yeah, people really, really, they have expertise and it's definitely moving to a demand model than a supply model. And I don't know, Gretchen, if you feel this way, but like it can take time and energy and, different structures need to be changed and or put in place to kind of bring in that new perspective. But in the long run, and maybe sometimes in the short run, it can save a lot of grief, for lack of a better word. So thank you, Gretchen, for that.
Yeah.
All right. Next, I'll go to Shelley, who in the chat says, people with lived experiences are in the center of learning communities, which drive learning cycles and build sustainable LHS.
That's great. And what is the mechanisms or processes because I don't have direct experience with learning health systems. I mean, how do you go about generating or gaining that information from lived experience? Is there like formal systems or formal and informal?
Here, Shelley, if you can type your answer in the chat, or otherwise I will enable you to talk if you would like. Just while we're waiting for her response, it looks
Oh,
like,
the chat.
oh, okay, sorry.
Sorry, okay. Oh, okay. Yeah. Okay. Um, sorry, Andy, were you gonna?
Oh, we just have, it looks like um Rhonda would like to speak,
Oh, okay.
also talk on this. So let's see. Um, okay, Rhonda, you should be able to talk now.
There we go. Thank you. So I just wanted to mention, I put a message in the chat. So I've worked with lived experience partners in the research realm for the last 10 years, and it is the most fulfilling and leads to the best research you can imagine. There are a lot of systems already in place to support this. A lot of work has been done in Canada, the UK, and the Netherlands. There's formal training available from McMaster University in Ontario. But probably the biggest aha moment we had was several of us were doing this work on our own, trying to figure out how to find lived experience partners, how to pay them, all these pieces, how to support them. And my manager at the time devoted resources to help me design a formal program to support this very important aspect of research. So we have a coordinator whose sole job is recruiting, screening, onboarding, and supporting lived experience partners, providing professional development experience. The same things you and I in our roles receive, and paying people for their work. We pay $35 to $40 an hour to our lived experience partners. Our health system works with children, teens, and adults with child onset disability. Many of the adults are on supplemental Social Security disability income, subsequently have very limited income requirements. And so we have our FER coordinator has a very open conversation about payment, whether or not they can even accept it, because it may put it over that threshold,
Yeah.
which would cause them to lose their public benefits, such as Medicaid, which is critical. So when it comes to paying and pulling lived experience partners into your learning health system, it's really, really important to think of all these different aspects and have a system in place that can support them.
Thank you, Rhonda, so much. It sounds like you really have best practice going on there. And I think that's what's one of the goals of this or one of the kind of knock-on effects of the WHO framework. It's like building those systems. I mean, the US is its own case with a kind of more fragmented system, but at least starting to ask those questions of how that can be done at scale.
Mhm.
So it doesn't have to be redone every time. And especially like, yeah,
Mhm.
research, a lot of the work has been done in research. But how do we then do it in policy? And
Yeah.
Emily in her video was talking about stigma and how do we kind of, look at this that affects or many conditions, and how do we kind of build these things from the bottom, but also the top that address as many things as
Mhm.
possible so they don't have to be redone every time, and you can learn
Yeah.
like have a blueprint that you can then apply to your own situation. So thank you so much for that. I am just I'll go into the Q&A, and if people want to talk more about their own experiences, that's great. I just didn't want to miss my chance to plug this. If you or know of anybody who would like to be a reviewer for the BMJ, please, you can share this QR code. And it's anyone with lived experience of healthcare, patient care, or family member. I know a lot of you are researchers or clinicians but like also probably wear a patient hat at some point in your life. And then I'm just going to go into the last slide, but I'm also going to just go grab, I really want to just give you a teaser of the lived experience collection. So hopefully it will encourage you to go to the website and read some of the work that these people spend a lot of time on. So that is my last slide, and I would love to hear any questions and more comments if you'd like. And again, I go by Sophie, but if you want to contact me, you can do so at my personal Gmail or at the BMJ. Please look me up on LinkedIn. Love to be connected and see what you all are working on or hear more about because I've heard from some of you. And I'm going to end this and then see if I can. Did I stop sharing?
Yes.
Okay. I'm just going to share one thing if that's okay when people are thinking of questions. Andy, I'm just going to share one more time.
Okay.
So this is the landing page for the Lived Experiences Expertise collection between the BMJ and the WHO. So it's hosted by the BMJ, so it's on the website. And can you see the screen?
Yes.
Okay, great. So as I mentioned, there's one editor. I wish I had shown you before. I kind of would have made more sense. So there's this editorial, which I wrote with two co-authors, kind of introducing the collection. So it's called collection because the BMJ has a number of collections where they work with another partner about a specific topic. And so there's the editorial and then analysis, the main author, the first author, Emily, you heard her speak. And then we have these opinion pieces, which are shorter than the analysis, but they're more like blogs, more personal. Oops, sorry about that. And here's just a little sneak peek of the topics. So please feel free to check that out and ask me. You can contact me after if you have any questions or comments about it. And now I'm going to stop sharing. Thank you.
All right. Well, thank you all. We have about 8 minutes remaining for the Q&A. If you have any questions or comments, please use the raise your hand feature. Otherwise, you can type your questions into the chat or into the Zoom Q&A. We already have gotten some questions and comments coming up. I'm going to start with Tracy. Tracy, you should be able to speak now.
Thank you. I think so. Can you hear me?
Yes, we can hear you.
Wonderful. Thank you, Sophie. This was wonderful, getting a deeper dive into this collection and your experiences and what BMJ is up to in collaboration with the World Health Organization on this really important. And I love and I resonate a lot with that emphasis you put on kind of the next big challenge. We've got the why kind of in progress, but this question of how. And I'm based at the VA and do both work in the practice, I guess, of engaging veterans or patients in the research process. And I also do a little bit of research in that area. And this, we're fortunate in our VA setting to be a national integrated health system that has embedded research. And one of the ways that we're moving to help support the how, because any of these really large research organizations that traditionally, haven't been necessarily doing patient-centered or patient-engaged research. It's, you're trying to move the Titanic, shift culture, and then meet researchers where they're at, where maybe they are facing those barriers of time and funding and even the skill, because it's, this growing skillfulness in engaging patients in the research, from the design question to dissemination and beyond. One thing I guess I would just share that's encouraging to me along those lines is that I am seeing more examples, more research looking at the use of engagement infrastructure, which was sort of what I was hearing you talk about a little bit there, Sophie, too. And the examples that come to mind are, like, in the US, PCORI, the Patient-Centered Outcomes Research Institute, has published some just description of the various engagement infrastructure, if you will, that's been part of their research networks. Our team actually is about to publish in the Journal of General Internal Medicine kind of a replication of sorts of what they did, but here in VA with 7 of our nationally funded research networks that create. One way to do this infrastructures is creating a standing engagement panel or group that all have, say, in one case, experiences with chronic pain and or opioid medication use for pain. I just wanted to share that and thank you for this. And then I'll end with a question. And that is for those patients or public individuals who sign up to be a reviewer. I'm just wondering if, kind of in the sense, in the vein of best practices, is it for any patient? Is there training or orientation that would support someone who maybe doesn't have, deep knowledge of research articles or medical care? So I'll stop there. Thank you so much.
Oh, thank you, Tracy. And just to pick up quickly on your comment and the governance, the kind of having that group. And whenever people ask me, where do we start? I always say, well, you're going to get a lot of bang for your buck, to use kind of coarse language. But if you kind of bring in governance, have a group of people who you can rely on to answer and kind of like at the BMJ, they're the patient editors, we're kind of like professionalized patient advocates, but we do questions. How can we find this person or how do we do that? We kind of we can advise on that. So that's a good way of, yeah, I love hearing about that. I should mention for the reviews, to answer your question, is that you can say what you would like to review. It could be a specific condition. It could be just, there's some patients who are happy to talk, review on any topic, because we do believe there are things that are not what's the word I'm looking for? Applicable to all conditions, especially if it's like around language or relationships in the at point of delivery, so things like that. But yeah, the training, there is very kind of clear guidelines on that. There's a lot of literature, and Emma, the other patient editor, and I are happy to meet with people who are interested in reviewing and help them out. But I mean, the goal is that the language, we try to only publish things that are not too kind of technical, that are accessible to everyone. And if not, we want the patient reviewer to say this is not. So if they're having trouble understanding it, other people will too, and that's really valuable information. So in summary, yes, we can provide training and you can review, and you can always say, no, I don't want to, or, you don't have to accept if you're sent a request to review something. So you can join the database and just use your discretion. Definitely.
Nice. One follow-up question on that, because that sounds fantastic. Do you do anything to like maintain contact with the folks in the database? I'm just thinking of, we've been like, one time we had like an excess in a recruitment, and then we invited the extra interest folks to kind of stay in like a pool for future possible involvement on studies, say. So have you gotten to that good problem to have of like such a large
Yes.
database?
Yes. Oh, sorry. I hope I didn't interrupt you.
No.
Okay. Yes, I don't know why I didn't mention this, but I started my relationship at the BMJ as a patient reviewer. So that was my first, and I just enjoyed it so much. And so I can't take any credit for this because it's already in place, but very, very good. And I try to continue the practice of, and Emma's really great, the other patient editor, sending out not monthly, gosh, a yearly newsletter, thanking everybody, providing stats on how many things, have been reviewed or gone to, kind of what stage they've made it to. You always get informed if something's been rejected or if it's been accepted. You'll get a list with you can see all the other reviews. So we try to be as transparent as possible within, keeping on the right side of legal issues, and not, and not anonymity and all of that. But try our best. But if you do review and you don't find a positive experience, let us know. I mean, that's why we started the policy of paying reviewers, just because, there was some feedback, and not necessarily for our journal, but for, that whole debate about not exploiting people with lived experience, to put it bluntly. It's probably not the right term, but yeah, to respect the time of people who are giving, sensitivities, giving their time, talking often about, sensitive things, being vulnerable, and just trying to show our acknowledgement of that. So again, yes, we try to, but let us know if we could do better.
Oh, that's great. I love like that modeling of that two-way communication is really beautiful.
Oh, thanks.
So
Well, that's
glad
the
to
only
hear it.
way. Only way it's gonna work. Oh,
Absolutely.
well.
All right. Well, thank you again to Sophie Walker for taking the time to give this talk, and thank you all for attending. Again, in closing, please join us for our next seminar on December 2nd at noon Central Time. This concludes our presentation. See you next time.
Thanks, Sophie.
Thank you. Thank you, Tim. Thank you, everybody.
Take care,
Okay, bye.
buddy.